Welcome back to the Health Longevity Secrets Show with your host, Dr. Robert Lufkin. His new book titled Lies I Taught in Medical School has been an Amazon bestseller for 15 weeks in a row and the #2 best-selling book on longevity. If you're enjoying this program, please like, subscribe, or leave a review. It will help others to learn about our work. And now, please enjoy this week's episode with Dr. Nathan Bryan and the mysteries of nitric oxide.
Hey everybody, I'm Dr. Robert Lufkin, and this week we get to unlock the secrets to a longer, healthier life with Dr. Nathan Bryan, who's a well-respected nitric oxide expert. So together we explore the groundbreaking work that has placed this amazing molecule at the forefront of longevity science. From Dr. Bryan's early days as a curious student to his innovative contributions along Nobel Prize laureates, Dr. Bryan takes us through the intricacies of how nitric oxide impacts everything from cardiovascular health to cellular repair. We delve into the compelling distinction between life-sustaining nitric oxide and the less beneficial nitrous oxide, understanding why this difference is crucial for our body's complex systems. Prepare to be astonished by the often overlooked factors that can influence our biological age. For example, we discuss how nitric oxide production wanes with age, yet how our diets, stress management, and even the use of common products like mouthwash play a significant role in this vital molecule synthesis. We learn how the oral microbiome is intricately linked to systemic health and how some oral hygiene practices may actually disrupt this delicate balance. Dr. Bryan offers a treasure trove of advice on optimizing nitric oxide levels through lifestyle choices, potentially slowing the aging process and enhancing both our heart health and cognitive function. In our final section, we uncover the profound connection between nitric oxide and the body's natural repair mechanisms. With Dr. Bryan's guidance, we probe into the significance of nitric oxide in stem cell differentiation and its broader implications in chronic diseases such as Alzheimer's and cardiovascular disease. We discover the transformative potential of replenishing crucial elements as well as the limitations of conventional drug therapies. Through Dr. Bryan's insights, we provide listeners with a pathway to reclaim their health and vitality by harnessing the power of this extraordinary molecule. So please join us for this enlightening conversation that bridges molecular science with actionable health wisdom. I'm proud to be hosting this summit as 25 world-class anti-aging experts reveal new science and breakthroughs you can use today to reverse the aging process in every aspect of your life. The free virtual summit starts June 20th, 2024. Please click on the link in the show notes to reserve your spot. This episode is brought to you by L-Nutra, maker of the Prolong fasting mimicking diet. If you'd like to try it, use the link in the show notes for 20% off. And now, please enjoy this week's episode. In this episode, we get to explore the fascinating area of nitric oxide and its effects on longevity. And we're joined by one of the world's experts in the area, Dr. Nathan Bryan. Nathan, welcome to the show.
Well, thanks so much for having me. It's a great honor and pleasure to be with you.
Tell us a little bit about your background and how you came to be so interested in this fascinating area.
Well, just like any career, it's been a journey. I started out, always interested in science and in medicine, and did, excelled that in high school. And then from there, I went to the University of Texas at Austin and got a degree in biochemistry, and quickly realized that the job market for a bachelor's degree in biochemistry wasn't stellar. So I realized in order to have a decent career, I needed to go and further my education. And I took a 2 to 3 year not really a sabbatical, but kind of figure out what I wanted to do in life. And then in 1999 or maybe 2000, I enrolled at LSU School of Medicine in a PhD program in molecular and cellular physiology. And it was there that I got introduced to the science of nitric oxide. It was a new field. A Nobel Prize had just been awarded for the discovery of nitric oxide in 1998. And I was very fortunate to meet Lou Ignaro when I was a student there. We organized a conference and had him come in and give a lecture on kind of the journey to the Nobel Prize, and had a chance to have dinner with him that night. And as a naive student, asked him a lot of naive questions, and turned out they weren't that naive. They just weren't many answers to the questions that I asked. And so for me, it was a very rich source of, a chance to make a difference and to make contributions to science. I trained with a guy, a pharmacologist that had been in the nitric oxide field for probably 20 years prior, Martin Feelish. And then from there, my role and really the work on my PhD was really in analytical chemistry, because we had to develop sensitive and selective instrumentation or methods to produce or to measure nitric oxide at physiological levels, which is nanomolar or femtomolar concentrations. And so once we figured that out, then we really had tools that no one else had in the field. So, as a student, I think I published 6 first author papers. I finished my PhD in a year and a half. Then from there, went and did a cardiology fellowship or postdoctoral fellowship at Boston University School of Medicine, where I spent 2 years as a postdoc, and again, publishing 10, 12 papers a year. And then I got recruited by Fred Murad, one of the other gentlemen that shared the Nobel Prize, to join his team at the Institute of Molecular Medicine at University of Texas Health Science Center in Houston. And from there, I was afforded a lot of the resources and just really intellectual freedom to ask any question that I wanted in the field. And we made a lot of discoveries. I filed a number of patents, and, I got several dozen issued patents in the field now. And it's really been a remarkable journey. But, it's really being able to ask fundamental questions and then being able to design experiments to answer those questions is really one of the great aspects about being a basic scientist.
Before we dive into nitric oxide and really explore that, I like to ask our guests maybe to set the stage by telling us what your view of longevity is. In other words, why do we age? There are many different theories, and all our speakers seem to have a slightly different, nuanced view of it. So maybe you could start off by just telling us the way you look at aging and longevity.
Sure. Well, we're constantly wearing ourselves out, right? We're in the aging, to me, is just the inability to replace new cells that work properly. And so when you answer that, when you try to figure out when you answer the question, what does it take to make a new cell that works properly, then you can really get to the fundamentals of longevity. Because we can't, we're exposed to so many toxicants in the environment and just daily activities that we have to replace and repair these old dysfunctional cells. And so aging, to me, is just the inability to replace these aging and dysfunctional cells. And so when we understand what that takes, then you can employ strategies to give the body what it needs to repair and replace dysfunctional cells. And then it's not just extending the quantity of life or the number of chronological years, but the quality of life. Because I think we would all agree that nobody wants to live to be 120 years old if we're not functional, and we have to have somebody take care of us.
Absolutely. Yeah. Well, now let's take a moment to start here and clarify one thing. Nitric oxide, there's another word, another compound that sounds very similar to it that we want to immediately distinguish, and that's nitrous oxide. So maybe just take a moment and differentiate those.
Sure. It's a common problem that people, when we talk about nitric oxide, they go, oh yeah, I love that. I love nitrous oxide. Well, nitrous oxide is N2O. It's a dental anesthetic. They're both gases. They sound very similar, but their physical chemistry is completely different. So nitrous oxide is the dental anesthetic that you get typically when you go to the dentist office, called laughing gas. And that's not nitric oxide. Nitric oxide is NO, and it's a gas, but it's a vasodilator. So I like to tell people, nitrous oxide will put you to sleep, and nitric oxide is what allows you to function and have a sense of alertness and wellness.
So what exactly is now nitric oxide then?
Well, as I mentioned, it's a gas, but it's a gas that's produced endogenously. It's naturally produced in almost every cell type. It was first discovered in our endothelial cells, or actually first discovered in our immune cells. That's how the nitric oxide was first discovered. But when it's produced, it has many functions. And its first function to be discovered was as a vasodilator, meaning that once it's produced in the lining of the blood vessel, it causes the smooth muscles surrounding the vessels to relax and dilate. And that causes a normalization of blood pressure. It regulates blood flow to every organ, tissue, and cell in the body. It's a neurotransmitter in the central nervous system. It's produced by our neurons. And as I mentioned, it's a molecule made by our immune cells, macrophages, neutrophils, monocytes, and it's critically important in killing invading pathogens from viruses to bacteria. And really, guys, over the past 2.5 years, we've really learned a lot about nitric oxide and the immune response, because we realized early on that the people that were getting sick and dying from COVID were the people who couldn't make nitric oxide. These were older patients with high blood pressure, diabetes, previous heart attack, African Americans, Hispanics. So it makes sense because, without getting too deep in the weeds, when you're exposed to a virus or a pathogen, which we're exposed to every day, we live in a microbial world, and some people get sick and some people don't. So how do you explain the difference between people who get sick and who don't? And for instance, I'm probably the best example. So when we're exposed to a pathogen, let's take COVID, for example. It's a respiratory virus that attaches to the epithelial cells, the ACE receptors. So when our body recognizes that, it mobilizes our immune response. We go to the site of attachment, and those immune cells generate a lot of nitric oxide. It shuts down the virus from replicating and propagating throughout the body, so you don't get sick. So in people who can't make nitric oxide or mobilize the immune response, there's no defense mechanism. So the virus attaches, it replicates, propagates throughout the body, and people get sick. And unfortunately, a lot of people died from that. So that's the importance of nitric oxide in a basic immune response and being able to mobilize a host defense.
So to recap then, nitric oxide is a fundamental, ubiquitous compound that's present virtually in every cell of our body. And it has these three really diverse but critically important functions of one, endothelium and blood vessels and cardiovascular disease, everything associated with that. And then two, brain function and, conceivably all the neurodegenerative diseases associated with that. And then one more is immune function. And, as you mentioned, COVID and everything else that the immune function does, it's amazing. So I guess, I don't know if I even need to ask this, but why is nitric oxide how is it related to longevity? And then we'll dive in a little bit there.
Well, when you look at, so there's an age-related decline in nitric oxide production. So if you look at, and these are human studies looking at what's called endothelial agonists. So if you infuse an agonist that would generally produce nitric oxide in the lining of the blood vessel, and then look at the resultant vasodilation. So there's about a 10 to 12% loss of what we call endothelial function per decade. This starts, late teens, early 20s, and a lot of this is dependent upon diet and lifestyle. But in general, in population-based studies, if you look at the average, by the time we're 40 years old, we only have about 50% of the nitric oxide we had when we were younger. And so now the science is clear with, I think, over 185,000 scientific publications on nitric oxide. The science is really clear that it's the loss of production of nitric oxide that's the earliest event in the onset and progression of every major age-related chronic disease. And now if you take that back to the question you asked of longevity, I think there's three main thoughts about longevity and the mechanisms of living longer. So one is telomere shortening. So for your listeners, obviously the telomeres are the ends of the chromosome that with each cell division, they get shorter, but you can control the shortening of the telomeres. So the science tells us that the shorter the telomeres, the shorter the lifespan. So if we can prevent telomere shortening or extend our telomeres, and that's associated with longevity. So that's one. Number two is loss of stem cell function. And so nitric oxide is the molecule that tells our own stem cells to mobilize and differentiate. So going back to this concept I presented earlier, that if the stem cells don't get the signal to go and repair and replace tissue, then they don't, and we age rapidly. And then the third one is mitochondrial function. Every age-related chronic disease is characterized by mitochondrial dysfunction. So the mitochondria are the energy-producing organelles of the cell, and it's nitric oxide that controls mitochondrial ATP production. It's nitric oxide that controls the number of mitochondria and how efficient they generate energy with oxygen. So I presented this probably 10 years ago, that nitric oxide is the unified theory of aging because it controls the enzyme that prevents telomere shortening. It controls stem cell mobilization and differentiation. and it controls mitochondrial biogenesis and mitochondrial function. So if you can't make nitric oxide, your telomeres get shorter, you lose stem cell function, and you develop mitochondrial dysfunction. And if you develop all three of those at the same time, then you're going to age rapidly and not have a very good quality of life.
Yeah, and you said that that normally nitric oxide function decreases with age, and you mentioned 40 years old and all. And I wonder, in longevity, there's such a great interest in developing clocks to measure aging, with the DNA methylation clocks or the chemical clocks, and basically people are making clocks of anything that changes reliably with aging. I wondered. It seems like, does nitric oxide decrease in a reliable manner? So that would be reliable as some sort of clock for aging as well?
Well, I think probably indirectly. It's very difficult to measure nitric oxide directly. So when we look at kind of this age-related decline in nitric oxide production, so that affects enzymatic production of nitric oxide, right? So the endothelial production of NO. But about 20 years ago, it was discovered that nitric oxide can be formed from certain components in our diet that overcome and that are compensatory to loss of endothelial nitric oxide production. And now you can measure this through, epigenetic changes in DNA methylation as kind of a biological clock. You can look at vascular aging and look at vascular function measurements that are an indirect measure of nitric oxide production. So when I talk about this age-related decline in nitric oxide production, that doesn't have to be the case. We now know that there are things you can do and strategies you can employ to prevent this age-related decline in nitric oxide production. And that's what we've been focused on really for the past 20 or 25 years in my research lab and research program. So we know, I'm the best example, I think, because I'm constantly measuring me and kind of what I do and how it affects, our health and longevity and our really functional output. So I just turned 49 on Saturday, but I have a biological age of a 32-year-old when we look at vascular measurements. So just because your chronological age doesn't have to match your biological age. To the contrary, I've seen 20, 25-year-old kids who have a biological age of a 60-year-old. And to the contrary, there's 60, 70-year-old people who have a biological age of a 40 or 50-year-old. So, there are things you can do that will move the needle and change this biological clock depending upon what you're using as your clock and what's your endpoint in biological measure.
Yeah, you mentioned you're almost 50 and your chronological age, but your biological age is close to 30.
That's right.
And that was with endothelial age. Was that a DNA methylation, or was that nitric oxide or imaging, or what test did you use for that?
There's a couple of things you can do. So I like to look at functional measurements. Imaging, whether you're looking at carotid intima media thickness, that's one snapshot in time, right? And I think that provides some good information. But really, the functional measurements for me, and what we use is what's called venous occlusion plethysmography, right? Or you can look at this non-occlusive plethysmography that looks at vascular structure and function. So there are algorithms. There's FDA-cleared medical devices out there that will give you your biological age based on the structure and function of your blood vessels and the ability of those blood vessels to produce nitric oxide. That's what I've used. I haven't used any of these other, DNA methylation clocks. As you guys probably do, you get pitched all the time on testing these and trying to, incorporate them into. But until they're really validated, for prognostic or diagnostic utility, then, I think there's limitations in what they mean.
So many things affect nitric oxide. It sounds like nitric oxide levels, in addition to aging. What about stress or mental health? What evidence is there for that affecting nitric oxide?
Well, it's a two-way street. Loss of nitric oxide causes, mental disease, mental stress, as well as, and then once you develop that, it further suppresses nitric oxide production. So it's this feed-forward mechanism that if you lose the ability to produce nitric oxide, it causes decreased blood flow to certain regions of the brain, develop neurological dysfunction, mild cognitive disorders, if not corrected, vascular dementia, and Alzheimer's. And stress, cortisol, the stress response actually shuts down nitric oxide, not only decreases its activity and functional activity, but also its expression. So we have to do a better job of managing stress, because that just, mounts on and perpetuates the symptoms of loss of nitric oxide production.
And you mentioned aging as a primary driver for lower levels of nitric oxide. What other things, you mentioned cortisol and stress, are there other things like diet or lifestyle or other factors that can affect how our nitric oxide levels or cause us to be deficient in them?
Well, it's the standard risk factors for cardiovascular disease. So smoking, sedentary lifestyle, high carbohydrate, kind of an unhealthy meal, obesity, and even some pharmacological drugs. We now know that antacids, specifically proton pump inhibitors, lead to an increase in a molecule called asymmetric dimethyl L-arginine, or ADMA, and that's been shown, to lead to a 30 to 40% higher incidence of heart attack and stroke in people who have been on PPIs for 3 to 5 years. That was work by my good friend John Cook out of Houston Methodist, I think back in 2015. So if you shut down stomach acid production, you shut down nitric oxide production, and a lot of bad things start to happen. You lose acid base regulation. You can't break down proteins into amino acids, so you get foodborne allergens and antibodies directed against certain peptide fragments. So we know that antacids are extremely bad, and in fact, as you know, they were never approved for chronic use. They were approved for acute use for chronic for gastroesophageal reflux disease. But yet people are taking these every day for many, many years, sometimes decades, and the consequences are very clear. So there are a number of, and really everything we do, it appears to disrupt nitric oxide production. The American lifestyle, the American diet, sedentary lifestyle, not sweating, the foods we eat, everything contributes to a loss of nitric oxide production. So it's really very tough, and it's hard work staying healthy and preventing this loss of nitric oxide production.
Yeah, you mentioned the venous studies as an endothelial marker for nitric oxide and all. The cardiac, the CT calcium score is one frequently used. And are there studies looking at either nitric oxide levels being related to that, or are they can you help your calcium score with improving your nitric oxide, or vice versa?
Well, anecdotally, we've seen that in a number of physicians and cardiologists that have patients with an elevated coronary calcium score, and then they'll, utilize some of our strategies, whether it's nitric oxide supplementation or just change in diet and lifestyle, and we've seen coronary calcium scores come down. But I think, I'm not sure if there's a clear association between really a good prognostic value of coronary calcium. Obviously, a high coronary calcium is not good. But what we really focus on in terms of vascular biology is, the pliability of the plaque or the stability of the plaque, because, you can have as little as a 10% occlusion in the coronary arteries and have an unstable plaque and have an acute myocardial infarction. And then there are people that have, greater than 90% stenosis that have lived with that for many, many years and never have a cardiac event. So for me, it's not about the degree of the stenosis or the occlusion in the blood vessels. It's about the stability of the plaque. And we know that if you can stabilize the plaque, then people are, more resistant to acute MI. And nitric oxide has been clearly shown to stabilize plaque. It prevents the inflammation, oxidative stress, and immune dysfunction, prevents platelets from sticking to the clot or to the plaque. So it's extremely cardioprotective. But to answer your question, there's no randomized placebo-controlled clinical trials on nitric oxide affecting coronary calcium scores that I'm aware of.
Well, we've seen, I guess, now that aging is a big risk factor for lower nitric oxide levels, and then the American lifestyle, which is more and more becoming the global lifestyle. So wherever you live, if you're even not in America, you're not off the hook. So what are the signs that I might be deficient in nitric oxide? Are there specific signs that would make us think nitric oxide, or is it more generalized things?
Well, that's a very good question. And people ask me all the time, well, how do I know if I'm nitric oxide deficient? And unfortunately, in the research lab, we can measure, plasma levels of nitric oxide metabolites or do biopsies and measure this, but clinically it's not used. So unlike, your cholesterol or vitamin D. You can't draw blood and say, oh, your numbers are bad. So we really have to rely on symptoms. And as you may imagine, when we look at the effects of nitric oxide on human physiology, the symptoms are pretty broad. So if you have an unsafe elevation in blood pressure, I mean, you're not making nitric oxide to help dilate the blood vessels and normalize blood pressure. And 2 out of 3 Americans have an unsafe elevation in blood pressure. So that's one. The first sign and symptom is really sexual dysfunction. That occurs in both men and women, because if you can't regulate blood flow through the production of nitric oxide to dilate the blood vessels of the sex organs, then you cannot get an erection, whether it's in men or women. So sexual dysfunction is what we call the canary in the coal mine. And it's really a sign and symptom of an underlying cardiovascular condition and nitric oxide deficiency. Diabetes, insulin signaling requires nitric oxide. And if you can't generate nitric oxide in the cells, then insulin doesn't get the signal, you don't get glucose uptake. So insulin-resistant diabetes is a sign of nitric oxide deficiency. Mild cognitive disorders, if you can't remember where you left your keys. So when we recall memory, we have to increase blood flow to the prefrontal cortex, and you do that through the production of nitric oxide to perfuse that region to recall memory. So if you can't make nitric oxide, then you develop mild cognitive disorders, which will develop into vascular dementia, and if not corrected, Alzheimer's. And then just loss of exercise capacity. If you get winded going up a flight of steps or walking, then that tells us that your body's not making nitric oxide. If you get, these vaso-occlusive crises or, pain in the legs, then peripheral artery disease is a sign of nitric oxide deficiency. So really, I think any major clinical symptom that we present with can be associated with nitric oxide. It may not be causal, but it's certainly an association with nitric oxide deficiency.
And I've seen people talk about test strips for nitric oxide that they put in their saliva, I think.
Yeah.
Are those valuable at all, or
Yeah, I developed that test strip back in 2010 because that was the first question people asked was, how do I know if I need this? And so, really the only way to create engagement and kind of the first and only point of care non-invasive diagnostic was to assess salivary nitrite concentration. So I just used some really old chemistry called the grease reaction that we've used for many, many years in the research lab, and applied that chemistry to the end of a test strip to where you can apply your saliva to that test strip. And if it turns bright pink, then that tells us that your body's able to recycle the nitric oxide production pathway through this enterosalivary circuit. So I think I tell people they're a good tool to have in your toolbox, but it shouldn't be the only tool you're using, because there's no such thing as a false negative on those tests. If you're negative, you're negative. Now, then we have to kind of interrogate and figure out, why are you nitric oxide deficient? But there are some false positives. So in the best example, I had a 50-year-old overweight, hypertensive, diabetic patient with erectile dysfunction use that test strip, and he turned it bright pink. Well, obviously, this guy is not replete in nitric oxide. He's obviously has all the clinical symptoms of nitric oxide deficiency, but he lights that test strip up bright pink. And so with further interrogation, we found that he had an active oral infection. And so the immune response in the oral cavity generates a lot of nitric oxide that shows up on the test strip, but systemically, this guy is completely devoid of any nitric oxide production. So those are the kind of caveats. So to answer your question, they're useful as a tool, but again, you have to be aware of some false positives.
And before we leave the oral cavity, I've seen on your website, I think, or on your podcast, talking about certain mouthwashes to avoid. Is that just because of the test strip they'll interfere with, or is that systemically they'll interfere with nitric oxide production? And maybe you could explain what the mechanism is.
That's it's a great intro into this new pathway we discovered probably 20 years ago. So independent of this nitric oxide that's being produced in the lining of the blood vessels and the neurons in our immune cells, we generate nitric oxide from the diet, from food we eat. So it's now realized that nitrate found primarily in green leafy vegetables can be reduced or metabolized by oral bacteria to nitrite and then to nitric oxide. And humans do not have this enzyme. Humans do not have a functional nitrate reductase enzyme. So we're 100% dependent upon the bacteria, primarily oral bacteria that live in the crypts of the tongue. These are facultative anaerobic bacteria, and we've been characterizing these now for more than 20 years. So what the science clearly tells us now is that if you disrupt this oral microbiome, you disrupt nitric oxide production from the diet. So now what we found, and I was on the doctor's show, I think last year, where we revealed that if you use mouthwash, your blood pressure goes up. And we and a number of other groups have published on this. But you also lose the protective benefits of exercise. So this told us that disrupting the oral microbiome is disrupting systemic nitric oxide production. And the mechanism still isn't clear. How is nitric oxide being produced in the oral cavity, affecting the second-to-second blood pressure regulation in the lining of the blood vessel? So we're still, trying to figure that out mechanistically. We have a pretty good indication that it's probably just inorganic nitrite or NO that's bound to glutathione, that's vasoactive, that's produced through this pathway. So the whole point is, if you disrupt the oral microbiome, you shut down nitric oxide production, your blood pressure goes up, and you become nitric oxide deficient. And now that creates a very interesting new kind of clinical readout, because 2 out of 3 Americans use mouthwash every day. Wake up in the morning, swish mouthwash. And I don't think it's coincidental that it's 2 out of 3 Americans that have an unsafe elevation in blood pressure. So we published on this, I believe, in 2019, that if you eradicate the bacteria through daily mouthwash use in young, normotensive, healthy individuals, you can make them clinically hypertensive in 7 days. And then fortunately, if you stop within 4 days of stopping mouthwash, you restore the diversity of the oral microbiome and restore nitric oxide production, and you can see a normalization of blood pressure.
Wow.
It's really any antiseptic mouthwash. So what we've used in these studies is chlorhexidine. It's a prescription antiseptic that's used primarily for chronic halitosis and some, serious periodontal disease of gingivitis. But, we've also done it with things like scope and Listerine, alcohol-based mouthwash, and they all disrupt the oral microbiome and all disrupt nitric oxide production. So I tell people, just like you have to get off antacids, you have to stop using mouthwash.
So there's no labeling that would make the mouthwash safe, because they're all basically antiseptic at some level. Right?
when it's listed as an antiseptic, there's kind of, in this natural alternative world, there's a lot of people that are using essential oils or some so-called natural rinses. And so, we just don't have any evidence whether they're disrupting that or not. So we have to rely, if it's antiseptic, it's antiseptic. It's killing the good bacteria, it's killing the bad bacteria, disrupting the diversity of the oral microbiome. And I tell people, the same reason you don't take an antibiotic every day for the rest of your life is because of the known consequences of disrupting the gut microbiome and getting systemic disease. So it makes no sense to take an oral antiseptic to disrupt the oral microbiome every day for the rest of your life.
I wonder if there are other things that we consume orally that might have a similar effect. I'm thinking like high alcohol concentration drinks, a liquor or something, could have that effect as well.
Well, I don't think, because when we're sipping on liquor or alcohol, we swallow it, right? So it doesn't have a long resident time in the mouth. But here's the one thing that we have discovered: fluoride. Fluoride is an antiseptic. It's found in municipal water. It's found in most toothpaste. Fluoride is an antiseptic. And that's the reason they add it to municipal water supply, to kill any potentially infectious bacteria that may be found in the water supply. So just like the fluoride in the water, the fluoride in the toothpaste acts as an antiseptic, and it kills the oral microbiome. So I tell people, you have to get rid of fluoride in your toothpaste. Fluoride's it's a neurotoxin. It kills your thyroid function. It competes with binding of the thyroid hormone with iodine. Most people are deficient in iodine. They're oversaturated with fluoride, and it disrupts your thyroid function.
I guess we just lost Crest as a sponsor for this program. Anyway, so there's a challenge here. Like, thinking about this, we all have decreasing nitric oxide levels with age, and probably with our lifestyle and our diet, and maybe our mouthwash and our toothpaste too. And then the symptoms we have to test for it are fairly common that most of us have anyway. So it sounds like then the best thing is to do things that will increase our nitric oxide levels, just assuming that they're low based
Right.
on our age and everything else. So how do you regulate that? When is enough enough? And well, maybe first start talking about what things we can do, maybe diets, supplements, and
Sure.
even pharmacology, drugs, medical, prescription drugs.
Sure. So that's a very common question. So people ask, well, how do I restore nitric oxide production and get my levels up to where they need to be? And I tell you, you have to do two things. It's very simple. Stop doing the things that disrupt it and start doing the things that have been clinically proven to promote it. So we talked about what to stop doing. Get rid of mouthwash, get rid of fluoride, get off antacids. And then, so what's clinically proven to enhance nitric oxide production? Well, moderate physical exercise. That's why exercise is medicine, because it stimulates nitric oxide production. It's probably one of the simplest things you do. And Americans aren't as active anymore. The old saying in Cooper Clinic, who's become a good friend of mine, Dr. Cooper, he says, people don't stop exercising because they get old. People get old because they stop exercising. And I think there's a very important lesson to be learned there. We have to move. We have to stimulate nitric oxide production. Sunlight, there's certain wavelengths of light, that frequency of energy stimulates nitric oxide production, releases nitric oxide that's bound to metals, releases nitric oxide that's bound to cysteine thiols on proteins, or even glutathione. So there's both kind of wavelengths in the UV range as well as the near and far infrared or full spectrum infrared. And then the other is, diet. Green leafy vegetables contain this molecule called inorganic nitrate that the body can then convert into nitric oxide. And, that's a challenge because we published a paper in 2015 trying to figure out how much servings of vegetables like broccoli or lettuce or kale or spinach would you need to eat in order to get enough nitrate to manage your blood pressure. And there's regional differences in the amount of nitrate that's found in vegetables. So it depends upon soil conditions, this whole field of agronomy. So it's very difficult to determine if you're getting enough nitrate from the vegetables you're eating. So what we've done and kind of trying to provide solutions to every step in the pathway that becomes disruptive is develop technology that does it for you. And that's the basis for many of my discoveries and technologies that we wanted to, in our drug discovery program with Dr. Murad at the Institute of Molecular Medicine, the whole concept was if your body can't make nitric oxide, then we have to do it for you. And then we now understand the enzymology and the biochemistry of the enzyme, that we can restore the function of that enzyme and actually improve the body's own ability to make nitric oxide. And, that's, I guess, my claim to fame is I was the first person to develop a solid dose form of a nitric oxide gas. So we create this lozenge, this orally disintegrating tablet that when you put it in your mouth, it's designed to have a resident time of about 5 to 6 minutes. But during that 5 to 6 minutes, we're liberating about 30 to 40 parts per million NO gas. And in fact, that's the same amount they use clinically in the pediatric intensive care unit for premature babies born with pulmonary hypertension, or even adults with pulmonary hypertension or during cardiopulmonary bypass surgery. So that's a clinically relevant dose of nitric oxide that's being produced in the oral cavity. It's vasoactive. We can see dilation of the carotid arteries within about 12 seconds of putting that lozenge in your mouth. Got a number of studies showing that it can normalize blood pressure, improve exercise performance. But also, 4 hours after this, and we published on this, I believe in 2011 or 2012, we see about a 15% improvement in endothelial function. So meaning that we've recoupled the nitric oxide synthase enzyme and now improved the body's endogenous production of nitric oxide. And now we've taken that technology and we're developing FDA-approved drugs using that same concept. We've got a COVID drug in phase 3 clinical trials. We've got a drug going into phase 3 clinical trials for ischemic heart disease, alleviating the symptoms of exertional angina. And then for this newer condition called ischemic non-obstructive coronary artery disease, which is a small vessel disease affecting women more so than men. But, they develop signs and symptoms of ischemic heart disease. You take them to the cath lab, an angiogram reveals that there's no obstruction in the large vessels, but the small vessels branching off the big vessels are clamped down and they become ischemic, but it's non-obstructive. So our nitric oxide opens up those small blood vessels and really has enormous clinical benefit for ischemic non-obstructive coronary disease.
So this lozenge is available now, and would you recommend taking that once a day, and then it lasts at least 4 hours?
Yeah, that's
What's
right.
the
So
regimen? Yeah.
I mean, I'm trained as a drug discovery chemist or biochemist, right? So when we first discovered this natural product technology, when I was still a professor of medicine at University of Texas, uh, we got a letter of opinion from some regulatory law firms on what do you need to bring this to market. And since it was all natural product chemistry, we really didn't need an IND or an investigative new drug application to do this. So we brought this technology to market many years ago. And so it's available as an over-the-counter. I've since developed a second generation of these lozenges. But really the whole concept of that is you take it, once or twice a day. And it's, as you know, as a physician, it's very difficult, if not impossible, to describe a one-size-fits-all as kind of a regimen. So if you're young, healthy, and pretty much in good health, then we say one lozenge a day is sufficient. If you've got some challenges, then we recommend one lozenge twice a day. But that's really been shown to provide, the pharmacokinetics and kind of the pharmacodynamics of this technology allows for one lozenge twice a day to give you 24-hour coverage.
And then we've talked about nutrition, we've talked about some lifestyle and these powerful supplements. What about the prescription drugs that are available? We've all heard of them, the Cialis, the Viagra and the BDE5 inhibitors. BD5. I think they're, yeah. What is this useful also for beyond erectile dysfunction, but just restoring NO levels for all the reasons you've mentioned? What's your thought on those?
That's a very good point. So the PD5 inhibitors, and those are drugs like Viagra, Cialis, and Levitra that are approved for the treatment of male erectile dysfunction. So there's a misconception in medicine and even in the lay public that these are nitric oxide donors. These drugs are not nitric oxide donors. They don't enhance nitric oxide production. What they do is they potentiate nitric oxide signaling. So I tell people nitric oxide turns the switch on, and these PD5 inhibitors keep this switch on for many hours. And that's the reason people are warned against 4-hour erections, unsafe drop in blood pressure, and all the side effects that come along with it. So nitric oxide binds to an enzyme, without getting too deep into the science. It creates a second messenger called cyclic GMP, and it's cyclic GMP that's responsible for the smooth muscle relaxation. So these PD5 inhibitors prevent the breakdown of cyclic GMP. So if your body can make a little bit of nitric oxide, activates the second messenger, then you potentiate the vasodilation. That's the reason it works in erectile dysfunction. But we also know that 50% of the men that are prescribed these drugs for either ED or BPH, urinary symptoms of prostate hypertrophy, don't respond. And the reason they don't respond to these medications is because there's not sufficient nitric oxide being produced in these patients to activate cyclic GMP. So there's no substrate for these drugs to work on. But here's what we've learned really over the past 10 years and people who have taken these drugs. And I think, so the point is if we can enhance nitric oxide production, we can decrease the dose of these drugs and make them safer, more effective. So I really like the once daily 5 milligram Cialis. And the reason for that is that studies have shown now that people who were taking 5 milligram daily Cialis during COVID had a lower incidence of infection and severity of the disease. Now there's clear evidence that people who have been on these drugs for many, many years, decades, have a lower incidence of Alzheimer's and vascular dementia. So there's something to be said about maintaining perfusion and circulation to every vascular bed, whether it's the vascular bed in the sex organs, whether it's the vascular bed in the coronary arteries or the brain. You have to maintain that circulation to get oxygen and nutrients to the individual cells. So those are good, but again, there's limitations to those. But I think if you use them, judiciously and, titrate down the dose, but really get to the root of the problem, patients are prescribed PD5 inhibitors because they're nitric oxide deficient. So I think my objective is to train physicians and even patients, say, let's get to the root cause. Your root cause isn't an overactive phosphodiesterase enzyme. Your root cause is a nitric oxide deficiency. Let's address that. Then there's no need for PD5 inhibition therapy. And I think there's a number of different mechanisms that can be exploited on that, because in Western medicine, there's never this discussion by most physicians of how do we wean you off drugs, right? let's come back, and if this isn't working, I'm gonna put you on more drugs. Well, going back to this concept we all started with, that many of these drugs interfere with the body to heal itself. So the more drugs you're on, the less ability you have to repair and replace dysfunctional cells and tissues, and your longevity is really compromised.
Yeah, it's fascinating. You mentioned the papers that are coming out showing the people on the BD5 inhibitor, the PD5 inhibitors have decreased incidence of Alzheimer's disease. And there's another one that came out with a longevity that they actually increase their longevity. And, you know, one would expect heart disease and everything else to be risk. And it's interesting that the clinical indication for the FDA approval was for blood flow to one particular organ, you know, in the,
well, we can't forget that Pfizer started this drug program for patients. It was either in, I believe it was for pulmonary hypertension, trying to dilate the blood vessels of the pulmonary circulation to alleviate pulmonary hypertension, which is still a poorly managed disease. And one of the side effects and common responses from the participants were better erectile function. So they abandoned the pulmonary hypertension and obviously exploited the market for erectile dysfunction. I think they've done very well with that.
Yeah, I don't know if it's apocryphal or not, but I heard this story that in the clinical trials that usually they're asked to return the drugs at the end of the trial, the unused drugs. But in this particular trial, patients were losing their drugs at an abnormally high rate, and they weren't returning them, which
became gold to them, right?
Exactly. This has been a great talk here. I want to be respectful of your time here. One quick question about cell repair. I think you touched on it before. Maybe you just revisit it. Nitric oxide, specifically as far as repair for longevity. You could just revisit that briefly.
Yeah, this really came on the radar in 1996 when it was discovered that, you know, when you lose nitric oxide, and this, I believe the study was done in enos deficient mice, we can genetically delete the nitric oxide producing enzyme. And it was found that these animals have less viable stem cells, whether they're the pluripotent stem cells that are mobilized. And then several studies later, and we even with Dr. Murad discovered that if we stimulate nitric oxide production early in the differentiation process, we can target certain stem cells to go to beating cardiac myocytes. So there's different stages in differentiation where nitric oxide comes into play. But if you can't make nitric oxide, then not only do the resident stem cells not get the signal to mobilize, they don't differentiate. And so then, you know, when people getting a lot of stem cell injections, you know, early on there were teratomas and a lot of adverse events from that. So again, if your body doesn't have what it needs to get the signal to repair and replace, then even giving exogenous stem cell therapy isn't going to fix the problem. We have to, and our whole process is we're trying to recapitulate physiology or restorative physiology. And that's the basis for our drug discovery. We're not developing pharmacology, we're developing restorative physiology. But I think on a broader level, you know, what I've learned in 20 years of science is that chronic disease, whether it's Alzheimer's, diabetes, autoimmune disease, or cardiovascular disease, is caused by two things and two things only. The body's missing something that it needs, or it's exposed to something that it doesn't. And so in that paradigm, there's really no room for drug therapy because, you know, going back to, early days in the early 1940s, most chronic diseases are caused from a nutrient deficiency. We know that most Americans, 95% of Americans are deficient in iodine, 75% of Americans are deficient in magnesium. And these are critical cofactors for enzymatic reactions. Then the other is the body's exposed to something that doesn't need, whether it's mold mycotoxins, environmental toxins, latent viral infections, something from the environment. So if we replete the missing nutrients and eliminate the toxins in the body heals itself. We're regenerative beings. We just got to get out of the way and stop doing the things that disrupt it.
Yeah, that's such a good point that for most of the chronic diseases we face, at least the ones associated with aging, pills and surgery may treat the symptoms, but they don't really change the underlying course of the disease. That's right. So important. Well, we've talked a lot about nitric oxide. I wonder, aside from the nitric oxide space, which is so exciting, what are the other areas, anything else in longevity that you're most interested in and most excited about?
It's a very good question, but I live in my own little microcosm of nitric oxide. And so what I try to do is, and I think that's one of the reasons we were successful in basic science, because as you guys know, basic scientists are you're always taught to go from bench to bedside, take your discoveries into the clinic. But that's like fitting a square peg in a round hole, right? Because everybody has their favorite molecule, but it may not be clinically relevant. So what I did, and that was the beauty of working at the Texas Medical Center, was we get to collaborate with a lot of really talented physicians. So we take really complex clinical observations, bring them back to the lab, model them in the lab, and then go back to the clinic. So really what works is bedside to bench, back to bedside. You have to model the disease, understand the etiology of the disease. And now you're not fitting a square peg into a round hole. So now what I like to do is take physicians who have complex cases, and then let's figure out, how does nitric oxide play a role in the etiology of that disease? And then start employing simple clinical strategies that gives physicians new tools to use in their armament. But so obviously I pay attention to the literature and other things that are relevant. I wasn't at all interested in immunology until obviously all of us were forced to become interested in immunology in 2019 or 2020. But now it's fascinating because now we have a clear understanding of nitric oxide's role in respiratory viral infection, which otherwise wouldn't have probably been that impetus for us understanding that.
Yeah, before we go, maybe you could tell our audience the best way for them to reach you or follow you on social media or your website.
Sure. Well, I send everybody to my educational website. I'm not here to sell you anything, but really just provide some objective education. And so that's drnathansbryan.com. I have a 6-minute video on there that'll tell you, kind of show you how nitric oxide works biochemically. I'm on Instagram, Dr. Nathan S. Bryan. I'm on Twitter at Dr. Nitric. And then obviously we live in a world where people are searchable, so you can search me online. Most of it's still good, I think.
Well, great. Well, thank you so much, Nathan, for spending time with us today in this session, and thanks again for all the great work you're doing in this really interesting space.
Well, thank you very much. It's a pleasure to be with you, Robert and Stephen, and thanks for the invite. I look forward to continue this discussion and helping us educate the world on nitric oxide.
If you are enjoying this program, please hit that subscribe button, or even better, leave a review. Your support makes it possible for us to create the quality programming that we're continually striving for.
Can I start? Is it recording?
It's already recording.
Oh, sorry. This is for general information and educational purposes only, and it's not intended to constitute or substitute for medical advice or counseling, the practice of medicine, or the provision of healthcare, diagnosis, or treatment, or the creation of a physician-patient or clinical relationship. The use of this information is at their own user's risk. If you find this to be on the value, please hit that like button to subscribe to support the work that we do on this channel. And we take your suggestions and advice very seriously, so please let us know what you'd like to see on this channel. Thanks for watching, and we hope to see you next time. You should say that.
That's good. You like it? You want to do it one more time, or is that good? I think that's good.
You need to save the recording.
Very good.